लेक्चर नाही घ्यायचं मला नका घेऊ म्हणजे मग मला दिवसभर ॲडजस्ट करता का चालू करू म्हणजे एखादा इव्हेंट मिळाला पण नाही आला तर तुम्हाला बोलतो म्हणजे कोटीतून त्यांना फोन केला बोलून घेतला ते सर पण आले ज्यांचं होते ते त्यांची आधीची होऊन बसली मग काही म्हणता येईल त्यांचा टाईम होता मग त्या मॅडम म्हणे मला फोनच कशाला केला तुम्ही मग खाली नव्हतं तुम्हाला सहकार्य केलं आम्ही तर तुम्ही आम्हालाच बोलून राहिले ठीक आहे म्हणतो आमची चूक आहे
काय नाव
रोबोट येते सर
हो ओके
सर
In the classification, and just in short see about the ones which are important, few of the important and common bone tumors in the body. So in bone tumors, our aim for today is basically the introduction, classification, and we take up in accounts a few brief benign bone tumors and malignant tumors of the bone. So what is a bone tumor? Is a neoplastic growth of tissue in the bone. This abnormal growth may be benign or malignant. Most common malignant tumor in the body in the bone is multiple myeloma, whereas the most common benign tumor in the bone is an osteochondroma. So how do you classify bone tumors? So classification of bone tumors is basically based on the histologic criteria. So when you see a when you see particular type of cell, tumor cell which is differentiated, and the type of the matrix which this cell produced, the classification is based on these two criteria. Further differentiation of tumors into specific types, into precise types, is done on the basis of electron microscopy and immunohistochemical staining techniques. So we have a simple classification, but quite important from exam point of view. We basically divided bone tumors into 7 categories depending upon what type of predominant tissue is present in the bone tumor, predominant tissue in the cells of the bone tumor. So first one we come is the one which is for skeletal tumors we have multiple tissues that can be formed. So the first one being bone tumors. First one being bone forming tumors. These are again we classified them into benign and malignant. So bone forming benign ones are osteoma, osteoid osteoma and osteoblastoma, whereas the malignant one is a single tumor known as osteosarcoma. Osteosarcoma is quite important, occurs in adolescent age group and can be quite devastating if not diagnosed properly. There are 3 different types of osteosarcoma, that is central, peripheral and parosteo. Second we come to cartilage forming. Again in the benign one we have a chondroma, an osteochondroma, a chondroblastoma and a chondromyxoid fibroma. Whereas in malignant we have a single important one known as chondrosarcoma, and again it is subclassified into juxtacortical, mesenchymal, dedifferentiated, clear cell and malignant. Marrow tumors are generally malignant tumors, they don't have a benign type. In the malignant ones, the important ones are the Ewing sarcoma, myeloma, multiple myeloma, or malignant lymphoma of the bone, or primitive neuroectodermal bone tumor. The remaining are quite easy to remember. Uh, when in vascular you have a hemangioma and glomangioma, whereas malignant is angiosarcoma. Others are other than the bone, cartilage, the vascular tissues. We have others which arise from the nervous tissue, that is the neurilemoma and the neurofibroma. In the malignant ones, we have malignant fibrous histiocytoma, liposarcoma arising from the fat, undifferentiated sarcoma arising from soft tissue, and adamantinoma. Giant cell tumor per se is a benign tumor but cannot be classified into a bone forming or a cartilage forming tumor. It is mostly a lytic lesion. It may be benign, intermediate, or malignant. We will come to the details of giant cell tumor further on. Other tumor-like lesions, which resemble tumors but are not technically tumors, they cannot be classified as malignant or benign. These are bone cysts, aneurysmal bone cysts or simple bone cysts. Fibrous dysplasia again causes skeletal deformities. X-ray picture appears to be that of a tumor, but it's a fibrous defect and not a tumor growth. So fibrous dysplasia is again classified into monoosteotic fibrous dysplasia or polyosteotic fibrous dysplasia, depending upon the involvement of the skeletal structures. Fibrous cortical defect is a single lytic lesion which commonly presents on the anterior shin of the tibia and appears to be a tumor-like structure. Has to be differentiated from Ewing sarcoma, which also has a similar kind of a picture. Eosinophilic granuloma is another tumor-like lesion. So we now come to the benign tumors. In the benign tumors, we have osteoma. Osteoma is a benign neoplasm characterized by proliferation of either the cortical or the compact bone or cancellous bone. So, if the common location is going to be endosteal or periosteal. This was described by Jaffe in 1935. The characteristic finding of osteoma is that it is more common in the head and neck regions, that is the skull and the facial bones, than the other bones in the body. So, what is it? It's basically a well circumscribed lesion composed of sclerotic bone. As you can see in the image, it is well circumscribed. The bone, on the X-ray, it appears more radiodense. Thus, it is a sclerotic lesion. Clinically, it has no significance. The only significance is that it may cause a deformity or it will cause a visible swelling present on the head neck face, which will not be appealing to the patient. When this osteoma bulges into the sinuses, it may produce obstructive symptoms. Treatment is usually not required. If it is symptomatic, it requires simple excision. Now we come to osteoid osteoma. It is a commonest true benign tumor of the bone. The etiology of the tumor is unknown. Probably the implicated etiologies are trauma and inflammation. It is classified based on the location into cortical, cancellous, intra-articular or subperiosteal. Osteoid osteoma is common at the age of 5 to 25 years of age. It is common in the lower extremity, especially in the tibia. Generally, it occurs in the diaphysis of the tibia. In the spine, it is common in the posterior elements of the spine. The patient usually presents with a nagging type of pain, which is worse at night and is relieved by salicylates, which is well relieved by salicylates. There is no or minimal clinical signs which can be elicited in case of an osteoid osteoma. Diagnosis is usually done by a CT scan or an X-ray. As you can see here, we have a CT scan picture of an osteoid osteoma presenting in the posterior element of the spine. This is a classical finding in case of osteoid osteoma, where it appears as a zone of sclerosis, in between which there is a radiolucent zone surrounded by zone of sclerosis and a nidus or a radiodense or radiosclerotic point present within the tumor that is usually less than 1 centimeters. Osteoid osteoma are quite benign, their course is quite benign and treatment is usually not required. When painful causing symptoms, the treatment is local excision. Excision of the nidus is necessary or may cause recurrence. the prognosis following excision is quite good. Now we come to giant cell tumor, osteoclastoma. It is the commonest benign tumor with variable growth potential. It is benign but malignant variations have been known to occur. Local recurrence is common after treatment of osteoclastoma. When we come to the pathology of osteoclastoma, the cell origin is uncertain. As the name suggests, osteoclastoma does not involve the proliferation of osteoclasts, or it is not a tumor of the osteoclast. It is basically, when you see a histological picture, you will see that there is undifferentiated spindle cells which are profusely interspersed with multinucleate giant cells. These multinucleate giant cells are quite often mistaken to be osteoclasts, but that is not the case. The stroma is highly vascular, and as you can see in the image, you can see that there are multiple spindle cells and giant cells which are interspersed, as the reddish colored blood vessels which are present suggest that the stroma is highly vascular. The osteoclastoma is quite common between the age groups of 20 to 40 years of age. It commonly affects, most of the tumors in the body commonly affect towards the knee joint or away from the elbow joint. So as you can see that the bones that are affected is towards the knee joint being the lower end of the femur, the upper end of the tibia, and away from the elbow joint being the upper end of the humerus, and one more area is the distal end of the radius, which are commonly affected by osteoclastomas. The tumor is usually located in the epiphysis. It presents with pain and swelling, or in case where it is ignored for a long duration, it may present with a pathological fracture. The local swelling is usually eccentrically placed on examination. Characteristic eggshell cracking, which is seen in osteoclastoma, may not be elicited in most of the patients. Due to the presence of a pathological fracture, the patient usually presents with a deformed limb. The fracture healing is quite poor due to decreased bone formation, and hence pathological fracture may need to be treated surgically. As you can see the X-ray, we have seen the X-ray of a distal end radius, which shows the lytic lesion present in the distal radius. So it is a solitary tumor. It may be lytic or loculated on X-ray. It is often subchondral in location. It is an expansile lesion. We have a soap bubble appearance, which is a characteristic finding of osteoclastoma. As you can see, there are multiple bubble-like structures with trabecula in the middle. There is no calcification usually seen within the tumor. Minimal reactive bone sclerosis seen in the surrounding areas, and as the tumor grows, the cortices are thinned. The tumor is, as you can see, the tumor is quite eccentrically placed, and the epiphyseal plate or the cartilage of the distal radius acts as a barrier for further tumor growth, whereas the cortex is getting thinned out. So what is the treatment of an osteoclastoma? Even though the osteoclastoma is a benign tumor, it has a high chance of growth and deformity. Hence, the excision of the tumor is the treatment of choice. The function should remain unhampered. In case the tumor is present in the distal femur or the proximal tibia, we may have to go with a few other additional procedures along with excision, reconstructive procedures to either maintain joint function or to improve the limb condition. So here you have the choices of reconstructions are the arthrodesis, in which the tumor is excised and the two joint surfaces are fixed to each other, thus producing an immobile joint or an arthrodesis. Arthrodesis can also causing excision, and arthrodesis may lead to shortening of the limb. So what we do is we do arthrodesis and bridge the gap using a fibular graft, and finally we come to arthroplasty, that is excision of the tumor followed by prosthetic replacement of the affected joint. The other modality is curettage with or without reconstruction. After curettage of the tumor, if there is significant bone loss or significant deformity which is present, then we have to go with reconstructive procedures. These may involve simple cement replacement, bone cement replacement in the tumor site of the tumor curetaged, or replacement with bone graft for reconstruction. Amputation following osteoblastoma is rarely done, but may be indicated in a neglected person where the osteoblastoma is involving more of the shaft and reconstruction procedures are not possible. Radiotherapy is used to prevent recurrence of osteoblastoma. These are the three important benign tumors. Now we come to two important malignant tumors, that is the osteosarcoma and the Ewing sarcoma. For the osteosarcoma, it is the second most common bone tumor. The first one being basically secondaries to the bone from the liver, from the prostate, the breast. So osteosarcoma is the second most common bone tumor. It arises from the primitive mesenchymal bone forming cells. It is characterized by rapid and aggressive production of osteoid in the bone. What is the etiology? It is the most common tumor occurring secondary to irradiation of the body. Pre-existing bone disorders such as Paget's disease are predisposed to developing osteosarcoma. Trauma may cause osteosarcoma in certain individuals. Disturbance in bone growth and maturation may also cause osteosarcoma. There is genetic predisposition in case of patient having a retinoblastoma gene or a P53 mutation in the body. This is usually associated with Leigh-Fraumeni syndrome, and Rothman-Thompson syndromes are commonly associated with osteosarcomas. A retinoblastoma is another condition which is commonly associated with the presence of osteosarcoma, and any patient diagnosed of retinoblastoma should be screened for the same at the appropriate age. Dysregulation of growth factors may also cause the formation of osteosarcoma in the body. Now we come to osteosarcoma. Osteosarcoma is basically classified into 5 types. It may be into 3 types. One is primary osteosarcoma, second is secondary osteosarcoma, and third is some unusual forms of osteosarcoma which are present. For us, important are only primary and secondary. Primary is primary basically have a conventional osteosarcoma which is subtyped as osteoblastic, predominantly bone forming, chondroblastic, predominantly cartilage forming, and fibroblastic, predominantly fibrous tissue forming. Osteoblastic type is the most common type. Other ones are small cell, which is a highly malignant tumor. Telangiectatic or osteolytic osteosarcoma has to be differentiated from others as it has osteolytic lesions and may be highly vascular. Intraosseous, well differentiated, and intracortical are 2 other types of primary osteosarcomas depending upon the location. Surface osteosarcomas are relatively less malignant or relatively less malignant. So they are parosteal, periosteal, and high grade surface osteosarcomas. Secondary osteosarcoma, as I said, is the one which is after irradiation of the body or secondary to Paget's disease, which is more prone to development of osteosarcoma. Few other unusual forms of osteosarcomas are basically subtypes of conventional osteosarcoma because of their biological behavior and similar typing. Osteoblastic osteosarcoma or sclerosing type. These are just to be enumerated, not important from undergraduate point of view. Clinical features of an osteosarcoma is more common in males. It is commonly seen in the 3rd to 4th decade of life. It is usually metaphyseal in location. The femur is the most common, lower end of the femur is the most common, followed by the tibia, the humerus, and it also occurs in the skull bone. The tumor usually presents as pain and swelling in the bone. The pain is boring type or dull aching type. It becomes worse as the size of the tumor increases. As the tumor size increases, the risk of pathological fracture also increases. On examination, osteosarcoma on examination is quite evident that the tumor inside may be malignant. Few findings of a malignant tumor are same with that of an osteosarcoma. Basically, you have a The skin over the osteosarcoma is shiny and reddened. The subcutaneous veins are quite prominent. The swelling is warm and tender. The margins are not distinct. As we had seen previously, osteoma and osteoid osteoma are quite a well-defined margins, whereas osteosarcoma does not have that. Regional lymph nodes may be enlarged due to metastasis. On pathology, as we saw that there are four basic most important types of osteosarcomas. So you have an osteoblastic type, which on gross pathology will give you a greyish white hard surface which is gritty on cutting. Chondroid type, which is opalescent and bluish grey. Fibroblastic or fish flesh sarcomatous type. Telangiectatic, as I said, has large areas of necrosis and blood filled sinuses. As you can see the histology, the pinkish structure which is present shows a large amount of osteoid matrix formation. This is the area of osteoid matrix formation. On X-ray, it is a quite classical features of osteosarcoma are seen. It's a metaphyseal tumor. There is irregular metaphyseal destruction which occurs. As the tumor grows, the periosteum acts as a barrier for tumor growth. The tumor starts growing below the periosteum, thus raising the periosteum from the bone surface. This raising of the periosteum produces an intense periosteal reaction which can be seen on the X-ray. The triangle from where the periosteum has been raised is known as a Codman's triangle. When the periosteum is raised, the Sharpie's fibers which attach the periosteum to the bone are also stretched out and blood vessels along with that. Calcification occurs along these structures, which gives a typical sun-ray appearance of osteosarcoma. As you can see in the X-ray, typical sun-ray appearance, it's not always this classic, but typical sun-ray appearance when present on X-ray is highly suggestive of an osteosarcoma. Certain biochemical markers that we do during in case of an osteosarcoma is the serum alkaline phosphatase, which is going to be raised, and the serum lactase dehydrogenase enzymes, which are going to be raised. So this is a malignant tumor. So what is the treatment of choice? Excision is the treatment of choice. Now excision may be wide local excision, en bloc resection, depending upon the extent and the involvement of the structures by the tumor. Excision with reconstruction, again as I said previously, excision with reconstruction. In this case, quite large amount of excision is done. So a procedure known as rotation plasty is quite effective. In this, the distal end of in case of a distal end, it's done only in case of a distal femur osteosarcoma. Here the tumor is opened surgically. Wide local excision is done by excision of the distal end of the femur and the proximal end of the tibia. The nerves and vessels are protected. The tibia is rotated 180 degrees and fixed to the femur, such that the ankle joint is rotated 180 degrees and helps it to function as a knee joint. Finally, arthroplasty is done with megaprosthesis in case of an osteosarcoma. Curettage with or without reconstruction is usually avoided, but can be thought about in early cases. In late cases where the tumor has spread, a large soft tissue involvement, metastasis is there, amputation can be used as a palliative mode of treatment. Radiotherapy is usually used. The tumor is not very radiosensitive, but it is used to prevent micrometastasis and for distant metastatic control where surgery is not possible. Follow-up is to be done for signs of recurrence. Recurrent osteosarcomas are quite common and prognosis is quite poor once recurrence occurs. Finally, we come to Ewing's sarcoma. Ewing's sarcoma is a highly malignant tumor occurring a decade earlier than osteosarcoma, commonly seen in 10 to 20 years of age. It is uncommon in the head and face and quite common in the diaphysis of the long bones, most commonly seen in the femur or the tibia. 1/3 cases occur in flat bones, that is the pelvis and the skull. Very rarely Ewing sarcoma present as a multicentric tumor with multiple involvements of bones. On pathology, it involves large areas of the medullary cavity. It is a grey-white tumor. Often it has a soft, thin structure and may resemble the pus. Bone is expanded. Periosteum is elevated with new bone formation in the subperiosteum. Once this ruptures, the cortex usually ruptures early in case of an osteosarcoma, in case of an Ewing sarcoma, and soft tissue spread may occur. Now, as you can see, the tumor comprises of sheets of quite uniform small cells resembling lymphocytes. As you can see, the cells are small and round. They have a large nucleus, less eosinophilic cytoplasm, resembling a lymphocyte. The tumors surround a central clear area and give a whorled pattern or a pseudo rosette pattern. The tumor grows quite fast, and by the time of diagnosis, metastasis is already present. Clinical features again are same. You have a pain and swelling. You may have a history of trauma, but it is usually incidental. The pain and swelling is usually associated with fever. Hence, the differentiation between an Ewing sarcoma and an osteomyelitis needs to be done. On radiology, as I said, the diaphysis is most commonly affected. You have a lytic lesion in the medullary canal of the long bones, which has cortical destruction. As there is layers of cortical destruction, it gives an onion peel kind of appearance. Or sun ray appearance may also be seen in case of an Ewing sarcoma, but it's quite rare as compared to osteosarcoma. Atypically may affect a metaphysis, and thus it may be confused with cases of osteomyelitis. For treatment, Ewing sarcoma is a highly radiosensitive tumor. It melts quickly but recovers fast. Most cases, metastasis has occurred by the time of diagnosis. Hence, local tumor control by radiotherapy and chemotherapy for systemic tumor control is usually needed. Excision is by the time of diagnosis, due to metastasis, excision can prove quite fruitless. Chemotherapy, the most commonly drugs used are vincristine, cyclophosphamide and adriamycin. The VAC regime which is used, it is repeated every 3 to 4 weeks for 12 to 18 cycles. In case of Ewing sarcoma, once diagnosis is made, prognosis is poor, as secondaries are quite common by the time of diagnosis is made. So this is all in brief a few tumors. Further tumors we will cover up in the next lectures. Thank you.